Good evening, everyone. Thanks very much for coming. I apologise in advance for any creaking in the background. I'm actually working clinically tonight. One of my colleagues is very kindly covering me for an hour. So there are some doors squeaking in the background. So as Andrew said, my name is Robert James. I'm a military consultant in emergency medicine and pre-hospital emergency medicine. And realistically, as a military consultant, you kind of need to have some interest in trauma. It's sort of a big part of what we do. So hence speaking to you tonight. I'm actually slightly surprised to be asked to come and talk again. I gave a talk for trauma care a few years ago where I got a bit nervous and spoke a bit quickly and finished about 15 minutes early, which rapidly, which resulted in a pretty early finish and totally screwed up the timings for Professor Carley, who was following me, who was live tweeting his slides. So I'm relieved that I seem to have been forgiven for that. But it has left me with a bit of a sort of almost fear of finishing early. And that's relevant because I was speaking to one of my registrars about this talk. And she said, yeah, you know, they bleed, they get shocked, you give them blood. At which point I thought that is not going to take 40 minutes. So it left me with a real thought of trying to work out exactly what I'm trying to achieve tonight in giving this talk and what I want to get over to you. And what I realized is that one of the best bits of advice I got given, or one of the best things I was told, was when I was fortunate enough to be working for an organization that sees an awful lot of trauma. And I was somewhat chilly, having been grilled pretty intensively for a few days on a course quite a long way up in London on the top of the helipad. And one of the comments made was, you've got to nuance your resuscitation. I think in order to nuance your resuscitation, you've got to be an expert. You've got to understand some of the stuff behind the patient you're seeing and understand what the processes are in order to effectively try and reverse them. So I'm hoping in this talk to try and give you some understanding of the processes, which will then allow you to come up with strategies to reverse the dying process or the pathophysiological process that's going on. So that's the plan. And you'll notice as well that the title I've put on my slide is slightly different from the title that has been advertised. Now, clearly the title that was advertised is a very good title. I think it's probably Professor Porter came up with it, so it's a very good title, given he knows a reasonable amount about trauma. But I've just tweaked it slightly because this is the first point I want to make. So shock and bleeding. Shock's a pathophysiological state that results from a disease process. And there are many different disease processes caused by the disease that is trauma. And all of those disease processes can lead to shock. So we've probably all been told that all shock in trauma is due to bleeding, or at least you should suspect bleeding first, second, third, and fourth. And that's absolutely reasonable. Bleeding is an important cause of shock in trauma, and that is what I'm going to spend most of my time talking about. But I think it's probably prudent just to have an awareness of some of the other disease processes in trauma that can lead to shock. And the first one of these is tension pneumothorax. Tension pneumothorax is relatively rare, and I think it's almost worth thinking about it as two separate disease processes. The first is a disease that occurs in spontaneously ventilating patients. So patients who are undergoing negative pressure ventilation. So that's what we're all doing at the moment. And in those patients, tension pneumothorax is a slow, predominantly respiratory pathology. And this is what Simon Lee Smith and his team had to say about tension pneumothorax. I'm just going to give you a couple of seconds to read that. So in the awake patient, it's a slow, predominantly respiratory pathology. In the ventilated patient, it's very different. The ventilated patient, it's much more rapid onset, and you get a much greater element of cardiovascular compromise as the disease progresses. And in this case, it can certainly be confused with bleeding. So the first thing to be aware of is tension pneumothorax. And tension pneumothorax is a form of obstructive shock. And another cause of obstructive shock that's important in trauma is cardiac tamponade. Now, I've put a pretty famous paper up about pre-hospital thoracotomy. I don't particularly want to go into the whys and wherefores of that. That's the other thing I don't really want to do in this lecture. I don't want to try and teach you how to do something practical, because I don't think a lecture is necessarily the right format to try and do that. But I do think this paper represents some important points. So cardiac tamponade can cause shock, it can cause cardiac arrest. And in this paper, what Gareth Davis and David Lockey describe is a group of 13 patients, all of whom received pre-hospital thoracotomies, 10 of whom had excellent neurological outcomes as a result of that. And the important thing that they found was that the patients who have a tamponade that do well are those who are aggressively treated as they arrest. So those that arrest in front of the HEMS team, or those that arrest when the HEMS team are a very short time away and the time to intervention is pretty minimal. So, cardiac tamponade is another important cause, and you need to think about it. And if you've got the expertise to treat it with a thoracotomy, then you should do that aggressively, because those are the patients that do well. And if you don't have the expertise to treat it, you need to get them somewhere as quickly as possible where they can treat it. And I think whilst this paper is all about patients with penetrating injury, it's certainly worth remembering that you can get tamponade in patients with blunt injury as well. The appropriate way to treat them is probably more controversial, but it's another thing for you to think about when you're assessing your shocked trauma patient. Because of course, we need to diagnose both the pathophysiological state, so shock, and try and come to an understanding of what's caused it in order to treat it. Neurogenic shock is another form of shock that can happen in trauma patients. So this tends to be in a spinal injury with an injury above the level of T6, which interrupts the sympathetic chain and causes a form of distributive shock. So patients get profound vasodilatation, and because they get no sympathetic innervation of their heart, they also tend to get bradycardic and a pretty poor cardiac contractility and cardiac effort. So again, in trauma patients, I'm probably not going to surprise anybody to suggest that if you're bleeding, the right treatment is to give blood. And in patients with neurogenic shock, it is probably important to give some volume if they've massively venodilated or vasodilated. There is an increased space to fill, so you need to fill that with fluid. But the treatment for this is probably vasopressors, which pre-hospital would probably deliver peripherally most of the time. You'd certainly deliver centrally if this patient was in the emergency department. And again, it's just a little bit unusual, and this comes back to that point that you have to understand what's going on in order to reverse it. And the final cause of shock that I want to talk about is this. So many of you will have seen this from Mark Wilson. It's sort of 5 years old now. And this is re-describing a phenomenon that was first described in the 1700s, that if people get a bang on the head, particularly a bang that causes a rotatory force to the brain, there is a chance that they will stop breathing. And this is how this situation is described in Mark's paper. But there's more to it than that. So certainly apnea is what can often kill the patient. And there's a good description in the paper, I suggest you read it, of the CT findings of patients who have what is suspected to be impact brain apnea. And there's a query about whether actually what they're getting is a hypoxic brain injury due to their apnea. So that's important, but it's not just about apnea. So this result of a central sort of brain injury is that you can also get a surge of catecholamines. You tend to get a hypertensive phase, and then the heart gets pushed beyond its optimal contractility. And following the hypertensive phase, there can be pretty marked cardiovascular collapse. And I'm sure many of you will have seen patients who you are convinced are bleeding. I have certainly given quite a lot of blood products to somebody who I'm convinced is bleeding. And then when you get their CT results, they're essentially uninjured from the neck down. And this is all a central cause of their pathology. So it's another thing to be thinking about. And this is really difficult. So probably the right treatment for the patients with this particular pathology is some beta blockers to try and antagonize the catecholaminergic surge. But you're a pretty brave person who gives beta blockers to a blunt trauma patient who's shocked. It's completely the opposite of what we would normally do. And in order to try and help people make these difficult decisions, again, the team from London's Air Ambulance have come up with this. Now, this is an excellent paper about Reboa. I'm not going to talk about Reboa. I suspect a chunk of you in the audience will be very relieved and a chunk of you will be slightly disappointed. But the reason I've brought this paper up is because of this. So this is what they've coined they've termed the hateful eight. And that is sweatiness, pallor, peripheral venous collapse, if they're ventilated, low or falling end-tidal CO2, hypotension, air hunger, tachycardia or bradycardia, and an altered level of consciousness. And those are clinical features that are supposed to help you try and differentiate between a patient who is shocked because they're bleeding and shocked for another reason. And I don't pretend this is easy. I certainly get this wrong frequently myself. But it's just something for you to try and think about in a bid to become truly expert and understand what's going on. Try and work out what the cause of shock in your trauma patient is. And those are essentially the major options that we've talked about now. So having hopefully made that first point, let's go on to sort of explain why we're talking about this, why are we bothering? So, as many of you will know, trauma is the leading killer in patients between the ages of 1 and 40. And if you look at both military and civilian case series, the number one cause of death in trauma is neurological injury, so primary brain injury. And as I'm sure this audience is very aware, there is little that can be done about primary brain injury after the event. The second leading cause of death and the leading reversible cause of death is hemorrhage. So in your shocked trauma patient who is bleeding, that is the leading reversible cause of death. And I'm an emergency physician, and I think on the whole, emergency physicians are relatively pragmatic, mainly because we're often not bright enough to be too ethereal about things. And if you talk about something being the leading reversible cause of death, it's useful to try and have some idea of how reversible it is. And this is a fairly famous rainbow graph, certainly famous amongst the Defence Medical Services. This was part of a paper written by a guy called Joan Penn-Barwell, who's an orthopedic surgeon in the Royal Navy. And what it shows really nicely is if you look at the x-axis, so the one running horizontally, NIS, so the new injury severity score, is essentially a marker of injury severity, so anatomical injury severity. And if you look in 2003, which is the line on the left of the screen as you're looking at it, the average NIS that led to a 50% survival during operations Telic and Herrick, which were the British military efforts in Iraq and Afghanistan, was about 35. Now that is a pretty seriously injured person. If you think our definition of major trauma in the UK is greater than 15, so they are firmly in the major trauma camp. But if you then look 9 years later in 2012, the NIS, so the injury severity that was associated with a 50% survival, is over 60, so it's about 62, 63. That's almost a doubling. And to give you some context, for those of you who haven't seen the NIS very much, a NIS of 75 is supposed to be universally fatal. So this is approaching something that is universally fatal, and you've got 50% of people surviving it. And the predominant injury pattern for patients particularly in Afghanistan, was exsanguination from lower limb blast injury. And so what, to me, this graph shows is that when you optimize your whole system, this isn't just the headline stuff, this isn't the MERT, this isn't the excellent care that was delivered at Camp Bastion Hospital, which was arguably the world's leading trauma centre for a while. This is about getting the whole system right. So this is about the bloke next to the bloke who gets blown up, putting tourniquets on early. But by optimizing your care of hemorrhage, you have nearly doubled the injury severity that people can survive. And this is why hemorrhage is so important. And as I just said, I hope I'm relatively pragmatic. So what I'd like to do now is just give you some questions to think about, and they're based on cases I've seen. And I don't want any answers now, but what I'm hoping is we'll revisit these questions at the end of the talk, and fingers crossed we'll have some slightly more definite answers, or certainly have given you a different way of thinking about these patients. So this is a patient, so he's essentially jumped from a 4th-story window as a result of some disturbance due to some substances he's been taking. So he's got a patent airway, he's obviously got a flail chest, he's got a palpable radial pulse, he's got a blood pressure of 80, he's got an obvious pelvic injury, his tummy hurts, and he's got an ankle fracture. He's got a reduced GCS, but he hasn't got any significant head injury obvious. So there's a question about whether his reduced GCS is due to poor perfusion. And what I'd like you to think about is, in this patient, how many of you would give him some volume if you were a road ambulance crew and you had normal saline or Hartmann's to give him? And once you've thought about that, I'd like you to think about these 2 questions. Would you change what you did if you had access to blood products? And would you change what you did if, instead of being 23, he was 83? So that's just the first case to bear in the back of your minds. And the second case I'd like you to bear in the back of your mind is this one. So it's another young male who's been in an RTC. It only happened about 20 minutes ago. He's just been extricated. And again, this is his physiology. So his A and B are fine. He's got a palpable radial pulse. He's got a systolic of 85. His pelvis is okay. His abdomen is okay. But he does have obvious bilateral femoral fractures, and his GCS 15. And again, I would ask you to think about whether or not this is a patient that you would be giving volume to. And then I'd like you to think about whether your decision would change if, instead of being 20 minutes post-injury, he was now 2 hours post-injury. So this is where we're going to get into the bit where hopefully we will become expert at understanding the processes that are going on. So this is probably pretty familiar to everybody. This is the lethal triad of coagulopathy, acidosis, and hypothermia. Perhaps what is less familiar to everyone is this. So this is the idea of the lethal diamond that has come out of a paper that's relatively recently published. I've just realised I've left the reference off, so I apologise. I'll certainly get anybody the reference if they want it. And you'll notice that they've still got hypothermia, acidosis, and coagulopathy, but they've added in hypocalcemia. And why is that important? So this is a relatively small series from St Mary's Hospital in London, and they looked at initially 87 patients. 55 of those, sorry, they looked at a lot more than that. They initially entered 87 patients who had had blood in the emergency department. And then they have got 55 patients who they have got a calcium level before they received any blood at all. And the traditional teaching is that packed red blood cells are preserved in sodium citrate. Sodium citrate sequesters calcium. So if you have been given packed red blood cells, you should get calcium to replace the calcium that's been sequestered as a result of that. This paper very clearly shows that over half of the patients who got to St Mary's who needed blood at some point, which is a marker of them being relatively seriously injured, were hypocalcemic before they'd received any packed red blood cells, in fact, any blood products at all. So the point of this paper, for me, is that it suggests that trauma patients may become hypocalcemic because of the process of trauma rather than because of the process of what we do to them. And there's certainly a suggestion that we should therefore be giving calcium potentially more aggressively in trauma. That's my opinion. It's something I'm trying to do some work to support, or to find out the right answer, should I say, because in my anecdotal experience, calcium has made a big difference to some of my trauma patients who, despite volume, weren't doing very well at all. When they got the calcium, things got better. And perhaps that's not surprising, because calcium is a direct ionotrope. So it helps the myocardium. And the other reason it's really important in trauma is it's an integral part of the clotting cascade. So if you don't have calcium, it's difficult to clot. So if you're hypocalcemic, your clotting won't be as good. So that's one element of what we're concerned about in trauma patients, or sort of in bleeding trauma patients, and one thing that we can think about trying to reverse if we diagnose somebody as bleeding. We certainly need to be mindful of hypothermia. There is no doubt that once patients get cold, probably properly cold, so certainly less than about 30 degrees, clotting doesn't work very well, and it doesn't work very well both because of the clotting factors themselves and also because of platelet function. So we need to try and stop that happening. Now, as I mentioned at the beginning, I work both pre-hospitally and in-hospitally. Pre-hospitally, it's pretty tricky to warm someone up, but what you can do by careful packaging is mitigate cooling and stop them getting any colder. And then once you're in hospital, you've then got more techniques to try and warm them up. Acidosis. So acidosis in trauma is largely a result of hypoperfusion. And it's important to remember that, because we're going to come back to hypoperfusion in a minute. When you hypoperfuse yourself, you'll remember this from A-level biology, you stop respiring aerobically, and you have to produce ATP via anaerobic respiration. And one of the byproducts of anaerobic respiration is lactic acidosis. And that matters because it makes you acidemic. Being acidemic stops your heart working as well. So at a time when your heart has to pump harder than normal because you've bled and you need to pump your remaining volume more aggressively, your heart's not working as well. And also this, sorry, that's a slightly fuzzy image. It looked better on my screen at home. This is thrombin, and thrombin doesn't work very well when you are acidemic. And thrombin takes us on to this. So this is starting to talk about coagulopathy. Now, there's been a lot of interest in traumatic coagulopathy recently. And my inner geek, this is my favorite graph, my inner geek's favorite graph, because I think it really explains beautifully the process of traumatic coagulopathy. So if you look on the z-axis, the vertical one, that's prothrombin ratio. So the higher the prothrombin ratio, the worse the coagulopathy. If you look across the x-axis, so the one that's sort of the traditional horizontal axis there, ISS, it's calculated similarly to NIS. There are some differences in it, but ISS is another marker of anatomical injury severity. And importantly for this, it's probably a marker of endothelial disruption. As you get more endothelial disruption, things get worse from a coagulopathy point of view. And then in the z-axis, so the one that's going away from you, back into the monitor that you're looking at, is base deficit. So the higher the base deficit, the worse the perfusion. And what this graph shows really beautifully is that the patients who have become really coagulopathic are those who have got both significant injury load and also have poor perfusion. Now, a bit like primary neurological injury, there's not that much we can do about the injury load the patient has received after the event, but what you can potentially do something about is the perfusion. And I think probably interestingly, part of the reason we saw so much coagulopathy in our last injured military patient cohort is because of the amount of endothelial disruption that causes. So the message to take away from this slide is that injury burden plus hypoperfusion leads to coagulopathy. And that's important because, as you can see, the more coagulopathic somebody is, the greater their mortality. So that's pretty key. So if we talk about the coagulopathy of trauma just briefly, there are two elements to it. And there is undoubtedly a slightly poorer clot formed in the first place, both in terms of how quickly that clot is formed and how the maximal amplitude of that clot. And that is demonstrated nicely here on something called a ROTEM. So a ROTEM is a form of thromboelastometry. And essentially what that means, and I can never remember which way around this goes, there are two devices. There's a ROTEM and a TEG. One has got a cup that stays still and a pin that spins, and the other has got a pin that stays still and a cup that spins. But it's a way of measuring the ability of the blood to clot. So there is some elements of traumatic coagulopathy that make the clot less good. There is also, and perhaps the key element, is this hyperfibrinolysis. So what that means is you form a clot and then for some reason you break it down again before you should break the clot down. In our normal states, as we're all sat here now, there are tiny clots forming and breaking down quite appropriately all over our body. But when you cut yourself, the clot needs to stay. And when you were a kid and you fell over and you grazed your knee, you had a scab for a while until it broke down. It didn't break down instantaneously. And that seems to be what happens in our trauma patients. And that happens for this reason. So there's a couple of bits of information you essentially need at the same time. So it's always difficult to work out exactly which order to do this in. But if you just believe me for a moment that activated protein C is important in this. So this is a model that Ross Davenport did. He was one of the trauma surgeons at Royal London. And Ross showed that in a mouse model, so a murine model, that were genetically unable to produce activated protein C, when they were injured and compared to a cohort of mice who could produce activated protein C, the mice who were unable to produce activated protein C had much less hyperfibrinolysis than the group that could produce activated protein C. So there is a theory that activated protein C is the thing that causes hyperfibrinolysis. And it does that via the medium of factor V. So as you can see, as you get more activated protein C, you get less factor V. And that is important in the development of the clot. And you get activated protein C formed as a result of a tissue factor pathway. And tissue factor is what is exposed when endothelium is injured. So that goes back to explaining why you get, or why part of the puzzle for causing coagulopathy is injury burden. So you get more tissue factor exposed. And this is another paper that shows when, again, another group of mice were treated with a tissue factor antibody, they were unable to produce protein C, or produced a lot less activated protein C, because they didn't have tissue factor. And this is a graph demonstrating that. So if you look at the amount of activated protein C, so in an uninjured mouse model, it's around 15. In an injured mouse model, it's around 30. And in an injured mouse model, but the mice were treated with the tissue factor antibody, it's back around 15. So it's almost as if they haven't been injured. So that endothelial exposure is really important. And this is why factor V is important. So activated protein C has two effects. Factor V is required to form thrombin, which is the basis of your clots. And if you don't have factor V, you can't cause that. And you can see that activated protein C reduces factor V, as we've talked about. And the other thing activated protein C does is it inhibits plasminogen activation inhibitor 1, which itself inhibits tissue plasminogen activator, which causes an upregulation of plasmin and breakdown products. So essentially, activated protein C inhibits the inhibitor of the thing that causes breakdown. So that is why you get greater fibrinolysis in patients with significant injury burden. And this again makes the point I made earlier about blast being particularly bad for this. So this is some work from Porton Down. If you look at survival, if you look at patients who are shocked, so this is a pig model this time, they were bled, but just bled. There was no significant tissue injury. Those that were then restored to normotension had 100% survival. If you look at the group that had blast injury, you can imagine that that causes a greater variety of injury. But again, those that were resuscitated to normal tension survived around the 65% mark. Those that underwent prolonged hypotensive resuscitation and were just shocked had a survival of about 60%, and then those who had blast and hypotension all died before the 4-hour mark. So this is again suggesting there's something different about blast, and also suggesting that prolonged hypotensive resuscitation, which was our paradigm for resuscitating trauma patients until you got surgical control of bleeding, is perhaps not right. And this is some additional work from Catherine Duran, which suggests that there may be an alternative method that we should be using to deal with these patients. And that is something called novel hybrid, or it's not that novel anymore, this is 10 years old, so hybrid resuscitation, where there's an initial phase where a degree of hypotension is accepted in most patients, stand-fast pregnant women, stand-fast children, stand-fast head injuries. But certainly in pure bleeding patients, an initial period of hypotension is permitted. The idea being that that allows a clot to form and solidify, but that after that period, and they have slightly arbitrarily chosen an hour, I don't think it matters if it's 50 minutes or 70 minutes, but somewhere around an hour mark, you would at that point resuscitate to pretty much normal physiological values, even if you haven't got surgical control of bleeding, because that stops that second part of the graph that's on the z-axis, that stops the profound hypoperfusion that really contributes to coagulopathy. And this is where it gets really horribly complicated. So these are two identical pigs injured in two identical ways, resuscitated in an identical way. And what you can see is that pig A has a base excess of -5. Now, I'm glad I don't have a base excess of -5 at the moment, but I don't think any of us would be horribly worried about those patients if we saw them pre-hospitally in our emergency departments or wherever else you work, in intensive care, in theatre, wherever it may be. However, their patient B, who had exactly the same injury pattern and exactly the same resuscitation, has suddenly got a base excess of -20. And the point of that is that some patients are perhaps genetically predetermined to do better with bleeding. And if we look, this is near-infrared spectroscopy, which is a way of identifying patients who have got better flow at a microvascular level. And you can see patient A has got better flow at the microvascular level, so the blue line is above the red line, and that correlates with their reduced base excess. And there's no reason we can think of this other than potentially genetic predisposition. There is probably genetic predisposition to surviving various things. So some patients get a nasty infection, get over it, and feel a bit rough. If patients end up in ITU with multi-organ failure, and it's not always obvious why some patients have gone down each pathway. And this certainly suggests that we need to understand better why this happens. It raises some interesting ethical concerns about patients who are genetically pre-programmed to not survive, whether it's appropriate to put them in high-risk occupations. And also it screams out for a better way of measuring our resuscitation and seeing our endpoints. So NERS is an example of something that could be done. There are other examples out there. Again, just some food for thought. So you certainly can't talk about hyperfibrinolysis without talking about tranexamic acid. So tranexamic acid is pretty much the closest thing we've got to a silver bullet in trauma. And what you can see is that patients that get TXA do better than those patients that don't get TXA. And if you look at the patients who receive massive transfusions, the patients with TXA do significantly better than the patients without TXA. So this is a really interesting paper from Professor Ian Roberts, who is sort of the professor of TXA, if you want to think of him like that. He was heavily involved in the CRASH-2 trial. I think the key points to take out of this is that from his point of view, there are no physiological cutoffs, so heart rate, blood pressure, for who should get tranexamic acid. Certainly my local ambulance service have implemented some physiological cutoffs and say patients without these parameters don't get TXA. That's probably not supported by the literature. There is no significant evidence of harm in anyone who gets TXA. And actually, the big concern is about venous thromboembolism, so DVT and PE. And what this shows pretty clearly is that in CRASH 2, for every 10 patients getting a clot in the no TXA group, only 7 did in the tranexamic acid group, which is statistically significant. So there is less venous clotting in the group that gets TXA. And this is what Professor Roberts says about it. He can say it much better than me. So again, I'll just give you a couple of seconds to read that. So what he's saying is that actually we should be pretty liberal in who we give TXA to. And if you've got any suspicion that they're bleeding, TXA is the right thing to do. It's another useful quote. And if you think about this on a population basis, TXA reduces death from bleeding by 1/3, however severe or however high your risk of bleeding to death was. So clearly, if you've got a 90% chance of bleeding to death and you drop that by 1/3, that's a 30% reduction, which is incredibly impressive compared to somebody who's only got a 1% chance of bleeding to death and you drop it by 1/3%. But there are so many more patients with a 1% chance of bleeding to death than a 90% chance of bleeding to death, that actually treating these patients with a relatively low risk of bleeding to death from a population point of view, you do more good and you save more lives. And certainly from a military point of view, we've taken this on to the extent that we are actively pursuing a project to get TXA auto-injectors so that troops can be issued with TXA that they can give themselves intramuscularly. And there's some pretty good data that intramuscular TXA is at least as effective as intravenous TXA. This is another paper about TXA that I want to put up because this was practice changing for me. And just in case anybody hasn't seen it, I thought it was worth flagging. So this is from the Lancet in 2018. And what it shows is that the earlier you give your TXA, the more effective it is. So you get so the earlier you give it, the better. You get a reduction of 1/3 in death through bleeding, but for every 15 minutes you delay, you get a 10% reduction in improved survival. So my practice before this was do everything you can to the patient, and then in the ambulance on the way to hospital is when they normally got antibiotics and TXA. I've now totally changed that, and I give them TXA as early as possible, always at scene, but just depending on what else is going on, it may be slightly delayed, but I really make an effort to give it early TXA. This is a really excellent paper written by some very clever people who know a lot about bleeding. And it is a very useful, very pragmatic guide to who should be getting blood and blood products. And in it, they really make the point that hypotensive resuscitation as a prolonged and protracted strategy is probably unhelpful. So I reckon that's about 36, 37 minutes, and I meant to talk for 40. So this is going better than the last time when I upset Prof. Carley, who I have to say was very nice about it, but I still try not to upset eminent professors. It's bad for your career. So if we go back to our first patient, and I appreciate this isn't interactive enough for me to really ask your opinions. So what I will talk about is hopefully your thought process, or what my thought process was with this. So this patient has got a radial pulse, but they have got a bit of altered mentation. They are undoubtedly hypotensive. And giving saline, as the Thor paper that you'll have just seen, if you read that, is not ideal. However, there is some unpublished work, again, in a pig model from Portendown, that suggests that giving saline in patients who are bleeding to death is better than giving nothing. So it's undoubtedly the right thing to give blood and blood products if you've got it. But if you've got nothing but crystalloid, then judicious dosing of crystalloid is probably better than nothing. So the point of this was to talk about crystalloid not being ideal, but if you've got nothing else, you may still choose to give it. Certainly if I had blood products, I think this is a patient who is likely to benefit from it, particularly if he's approaching an hour post-injury. And what if he was 83? Now, this is where really thinking about the processes comes to, and hopefully the point of me having talked to you for the last 40 minutes, this will make sense now. So if he was 83, he will have a significant burden of atherosclerotic disease. His endothelial perfusion will already be worse because his perfusion everywhere is worse. So pre-injury, it's worse. So in older patients, I think there's an argument for being even more aggressive with volume resuscitation because they're going to get that endothelial hypoperfusion more profoundly, and they're going to start pushing into that coagulopathic state more rapidly. And this is your next patient. If you remember, this was a driver of a car who at 20 minutes had this physiology. And I think at 20 minutes, it's probably reasonable in somebody's GCS15 with a palpable radial pulse to not give him any volume. However, if you were 2 hours post-injury, you have at that point passed through your initial phase of hypotensive resuscitation where for an hour or so that's reasonable. And it's pretty unlikely that even in a young person, 88 systolic isn't a normal blood pressure for them, particularly if they're in pain with bilateral broken femurs. So I think the point of that is to encourage you to really think about where you are in that patient's journey and what the right thing to do is. And at 2 hours post-injury, you're probably now in the point we need to be preventing that coagulopathy. So that patient I would then give some volume to 2 hours down the line from injury. So I hope that's been a useful sort of flip through some thoughts around shock and bleeding in trauma. I hope I've attained my goal of giving you the knowledge to make you be able to really think through the processes, the pathophysiology of what's happening to your patient and intervene aggressively and appropriately to reverse the process that is making your patient ill. So at that point, I'm going to hand back to Andrew, I presume, to curate some questions.